Heart failure or congestive heart failure is a progressive disease that is defined as the inability of cardiac muscles to pump sufficient blood to meet the peripheral and cardiac oxygen demands and the metabolic demands. Usually it is caused by an impaired ability of cardiac muscle, particularly the left ventricle, to pump enough blood out of the heart and to meet the workload requirements of both the cardiac tissue and the periphery. Ultimately, this results in an increased blood volume and interstitial fluid. 70 to 80% of the cases of heart failure is due to coronary artery disease, while the remainder may be due to uncontrolled hypertension and also drug and alcohol abuse. There is a depression of ventricular function, and either it's coronary artery disease, hypertension, which results in dilated cardiomyopathy, or due to valvular disease or congenital heart disease. This causes a restriction of ventricular filling, which could be due to mitral stenosis, pericardial disease, or recessive cardiomyopathy. Other precipitating factors that may worsen heart failure or augment heart failure is increased sodium levels, non-compliance with antihypertensive and anti-congestive heart failure medications, an acute myocardial infarction, exacerbation of hypertension or uncontrolled or resistant hypertension, infections, infective endocarditis, and pulmonary embolism. Now, typically, heart failure is a progressive disease and congestion will not occur initially. Congestion is something that happens as heart failure progresses. And the typical symptoms of heart failure is exercise intolerance, shortness of breath, dyspnea and orthopnea, ultimately tachycardia, and as it progresses it causes pulmonary and peripheral edema, and subsequently cardiomegaly, which is enlargement of the heart or left ventricular hypertrophy, and ultimate fatigue. And as this progresses, edema happens. Usually the edema starts at the ankles and then it progresses to the rest of the body. The patient develops shortness of breath, edema of the ankles and legs, fatigue and a lack of energy, problems with sleeping. They may need 2 or 3 pillows to prop themselves upright in order to slow down the pulmonary edema and the congestion. Swollen abdomen, cough with frothy sputum, and of course urination, particularly at night. Now, heart failure basically is progressive, and as it progresses, it is the homeostatic mechanisms or the reflex mechanisms that basically become detrimental to the disease and worsen it. So as it progresses and as myocardial contractility goes down, 2 systems come into play. One is increased sympathetic stimulation that basically tries to increase cardiac contractility by increasing the interaction of norepinephrine with the beta-1 receptors in cardiac tissue. And at the same time, the sympathetic stimulation activates the renin-angiotensin system, because as cardiac contractility goes down, the kidney detects this as hypoperfusion. This hypoperfusion activates the beta-1 receptors in the juxtaglomerular cells, and now we have angiotensin II and aldosterone being released. This attempts to try and increase cardiac contractility by increasing the total peripheral resistance. Unfortunately, as was discussed in the antihypertensive lecture, both angiotensin II and aldosterone cause cardiofibrosis, and they directly cause mitogenesis. And as a result, they will cause cardiac inflammation. Norepinephrine, on the other hand, will also worsen ventricular hypertrophy and cause left ventricular hypertrophy and cardiomegaly. As these processes continue, unfortunately, the patient develops tachycardia. They will have fluid retention, which causes an increased preload, vasoconstriction, which continues to increase afterload, and ultimately ventricular hypertrophy, cardiac remodeling, and the left ventricular wall thickens, the chamber does not increase in size. Ultimately, this ends up with systolic dysfunction or a reduction in myocardial contractility, and basically diastolic dysfunction, which is a reduction in ventricular filling. As this process continues and there is increased retention of sodium and water, this causes significant edema, and as a result, this is what is responsible for short breath and ongoing edema. As a result, one of the main issues of treating heart failure or congestive heart failure is to try and inhibit angiotensin II and aldosterone, because they are directly causing cardiofibrosis, and literature states by inhibiting angiotensin II and aldosterone you reduce the mortality and morbidity by 30 to 40%. Other risk factors are age, coronary artery disease, hypertension, alcohol, smoking, cardiotoxic drugs such as some of the anti-cancer drugs, rheumatic heart disease, and thyroid disease. So you have increased sympathetic discharge, which ultimately tries to increase the heart rate and cardiac output, causes vasoconstriction, and trying to enhance venous return, increase cardiac output. Unfortunately, the fluid retention progresses and the patient becomes significantly edematous and has a significantly increased blood volume and a significantly increased circulating angiotensin II and aldosterone. This causes the myocardial hypertrophy and cardiac remodeling, cardiofibrosis, and there is a change in cardiac size, shape, and composition. Basically, this causes myocyte slippage, incorrect collagen deposition, fibroblast proliferation, and ongoing inflammation that worsens the myocardial hypertrophy. And this continues to cause an increase in angiotensin II, aldosterone, norepinephrine, endothelin, which causes further vasoconstriction, and vasopressin. So as the cardiac output decreases, you have cardiac hypertrophy. You have the activation of the sympathetic nervous system that releases more norepinephrine, and the reduction in renal blood flow continues to activate the renin-angiotensin-aldosterone system. All of the three put together causes edema, significant cardiofibrosis, significant ventricular hypertrophy, and continues to worsen the heart failure, which very quickly progresses congestive heart failure. This is basically to show you what happens in heart failure where you have a normal sized heart compared to an abnormally large heart that has resulted from the ongoing hypertrophy in heart failure. So this continues to cause increased angiotensin II, salt and water retention. It tries to increase vascular volume. However, this homeostatic mechanism, which is compensatory, becomes extremely detrimental to the whole situation. The treatment of heart failure and the classification of heart failure is based on the New York Heart Association guidelines. There are 4 categories. A is patients who are at very high risk, however they do not have any structural changes. This risk is associated with systemic hypertension, coronary artery disease, drug abuse, and alcohol abuse. Category B are patients who do have structural disease or structural heart changes but do not have the disease. Example, left ventricular hypertrophy or fibrosis. Category C are patients who are currently having symptoms of heart failure and have significant structural changes. Category D are those patients who are either decompensated or have progressive heart disease despite therapeutic intervention and require hospitalization and basically ventricular assistance. The therapeutic goals is to basically remove the symptoms, inhibit the ongoing renin-angiotensin-aldosterone system activation, and to reduce the activation of the sympathetic system, and to try and increase cardiac output if required, and to manage the heart failure symptoms. The first line drugs, or the drugs of choice for treating heart failure, is always an angiotensin converting enzyme inhibitor and an aldosterone antagonist. Should congestion occur, this requires a loop diuretic, which is a high ceiling diuretic, and beta blockers are also added to the regimen. Should an increase in cardiac contractility be required, then digoxin basically is the first line